So now we are going to learn about the external ear pathologies. Okay, external ear pathologies. So whenever we talk about external ear pathologies, first of all we need to talk about the congenital pathologies. Okay, so in the congenital pathologies you have anoxia, you have microtia. Okay, microtia. You have bat ear, loop ear. Okay, so anoxia means absence of pinna, absence of pinna. Okay, microtia means there's a small pinna, and bat ear means there is extra amount of cartilage, that that makes our ear look like a bat's ear. Okay, loop ear means like a loop. Okay, so we don't need to remember too much, but the main important being anoxia and microtia. What is the clinical significance of understanding anoxia and microtia is a person having anoxia, and if he has a hearing loss. Okay, if he has a hearing loss, then I cannot use the hearing aid. Okay, so instead of using a hearing aid, I will use a bone anchored hearing aid. So what is this bone anchored hearing aid? Bone anchored hearing aids are something different than the classical hearing aids. Okay, the classical hearing aids are of basically, it might be behind the ear hearing aid, it might be into the canal hearing aid, or it can be completely in canal hearing aid. Okay, in the canal and completely in canal hearing aid. Okay, but in these condition of anoxia, I cannot use hearing aids like these. Okay, so I have to go for Baha means where I will actually, there's a screw, titanium screw, which is actually implanted into the temporal bone. Okay, and after being implanted, we just insert a disc shaped vibrator type outside, and this tends to send the sound to the inner ear. Okay, in this way. But to perform Baha, at least the thickness of the temporal bone required is at least 5 mm, and that is only attained at the age of 6 to 7 years. So if a person is born with anoxia, I cannot wait for 6 to 7 years to insert a Baha. So what will I do? I will use a soft banded hearing aid. Okay, it's similar to that of like this type of device, but it's like a band. So if this is a person, then the band is inserted like this over here. Okay, this is like a soft banded hearing aid, and it is kept at the level of your mastoid. So this is kept at level of your mastoid. Okay, so this was about the generalized idea. Now let's come to the diseases proper. Okay, so whenever we talk about the diseases of the external ear, very confusing is malignant otitis externa. Usually students really get confused with this word malignant doesn't mean it's malignant. This is a misnomer. Number one, this is a misnomer. Secondly, otitis externa means it is involving the external ear, so it involves the EAC, external acoustic canal. Remember, the external acoustic canal, this canal, the lateral 1/3 is actually cartilaginous and the middle 2/3 is bony. Okay, so in this cartilaginous part, in the floor area, there are certain sieves like projections. Similarly, in the bony area also there are sieve like projections. So bone are hard. So from hard you can remember the foramen of Huska, and from cartilaginous part you need to remember foramen of Santorini. Santorini means S for soft. Okay, Santorini and the foramen of Huska. So from this foramen of Santorini, the infection can actually trickle down. Let's make infection with the yellow color. It can trickle down to the parotid, and from this hard part it can actually trickle down to the temporomandibular joint. Okay, so malignant, it is a misnomer. And why is this malignant term used? Because this is a locally aggressive type of disease. Okay, so it occurs here and it totally involves all the areas, and it's very aggressive. This happens usually to someone who is immunocompromised, Okay, immunocompromised, someone who is diabetic, someone having HIV. Okay, and how will the patient present with, suppose this is the patient's ear, so we can see certain greenish blackish type of discharges from his ear, and this are basically they are actually granulations. Okay, greenish blackish discharges are there, and a lot of granulation tissues are seen in the opening of EAC as well as in the in the opening of the this ear as well as in the EAC. Okay, so whenever we talk about malignant otitis externa, the major pathology behind this one is lateral skull base osteomyelitis. Lateral skull base osteomyelitis. And this becomes a devastating condition. We don't want this to happen. So what is the culprit behind this? The culprit being is Pseudomonas. Pseudomonas aeruginosa. As well as aeruginosa, as well as some anaerobes. Okay, so we just give drug of choices ciprofloxacin as well as metronidazole. Okay, cover aerobic as well as anaerobic in this condition. Okay, remember that this transfer, this this patency is still 4 years of age. After 4 years this will end. Okay, so before 4 years this patency is open and it can travel down to TMJ or this one. Now what is the diagnosis of choice and what is the prognostic marker? So for diagnosis you will basically go for technetium 99 scan, and for the prognosis you will go for gallium scan. Okay, so technetium 99 and gallium scan are actually there. So technetium 99, it remains there for about 9 to 12 months. Okay, technetium 99, if you do technetium 99 once, it will remain positive for 9 to 12 months. So what is the use of doing technetium 99 as a prognosis? So for prognosis you have gallium scan. Remember, prognosis has the word G in it. That is why G is referred to gallium scan. You can remember in this way. And this gallium scan, it actually shows the activity. Okay, this gallium scan, it actually shows the activity of your leukocytes. Okay, it shows the activity of leukocytes. So as inflammation decreases, as leukocytes decreases, the gallium scan will actually decrease, right? So this is the best prognosis matter. For diagnosis, osteoclastic activity, that activity is actually shown by technetium 99. It is shown by technetium 99. Okay, so I hope this much is clear. Okay, now let's move on to the next topic, very very important, otitis externa. Let's talk about localized and diffuse. So what is otitis externa? Otitis externa is actually the disease of the external ear. The localized otitis externa and diffuse otitis externa. Localized otitis externa is caused by Staphylococcus aureus and diffuse is caused by Pseudomonas. Remember, whenever there is a question regarding otitis externa, there is always a history of ear pricking. Either any kind of trauma, that trauma may be a forced bite, okay, or it might be ear piercing, okay, anything as such. There can be localized otitis externa. Remember, this is the opening of EAC and this is your ear, suppose. So the opening consists of a lot of hair cells, right? So if I just go and just clean my ear also, and if this earbud causes trauma, micro traumas to the hair follicles, and these follicles are actually infected and they present with folliculitis, and this is what is localized otitis externa. Okay, and one more thing I would like to add upon here, that So folliculitis means it there is a slight swelling. Okay, there's a slight swelling. Sometimes this swelling is actually self-resolving. You don't need to do anything. But the major thing becomes when the swelling becomes so big, sometimes it can occlude the EAC. It can occlude the opening of EAC, and you are not able to visualize the tympanic membrane. If it is small and if you are even able to visualize the tympanic membrane will be normal. The tympanic membrane will be normal. So this type of follicles, if it burst, then it will lead to the formation of an abscess. It will lead to the formation of an abscess, right? And this can actually cause post oral lymphadenopathy. So it can actually involve the post auricular lymph node, and there might be posterior superior wall of EAC, as well as posterior superior wall of EAC, as well as post auricular groove might be obliterated. So can you tell me one condition where the posterior post oral groove is obliterated? So the condition where post oral groove is obliterated is acute mastocytitis. So in the case of acute mastocytitis, the post oral groove is obliterated. So don't be confused. In the case of acute mastocytitis, there is ironed out mastoid. But in the case of this lymphadenopathy secondary to folliculosis, there is no ironed out mastoid. And associated with acute mastocytitis, there is a secretion from air, and there is only secretion in the furunculosis if this furuncle burst. There might be certain granulation, certain abscess, fluctuant swelling may be there. But in the case of diffuse type, the history is similar, scratching and all this history, but extra history is entrance of water or oil inside the EAC. That will lead to diffuse swelling, and this is caused by Pseudomonas. The treatment for localized is flucloxacillin plus 10% ictamol in glycerin plus analgesics plus fluid intake. Okay, this will actually help the patient. But in the case of this one, the treatment would be ciprofloxacin, 10% ictamol and glycerin is very important because that tends to reduce your inflammation. Okay, edema. Ictamol, remember again from the word itself, ictamol has I in it, so it decreases irritation, and glycerin, it has E in it, 2 E's, it decreases edema. Okay, next is fungal otitis externa. Next is fungal otitis externa. Remember that in the case of diffuse otitis externa, there is no abscess, no granulation, no obliteration of your post-auricular wall. Okay, and there is a history of discharge. Discharge is seen. Okay, you don't need any bursting or anything because there is no furuncle here, but here bursting was required for a discharge to happen. Fungal otitis externa is caused by Aspergillus fumigatus, Candida albicans, and niger. In Aspergillus niger. Now these organisms, niger means black, albicans means white, fumigatus means green. So the colony is green, white and black. the EAC structure. Sometimes tympanic membrane also appears very black in the case of Niger, or green in the case of fumigatus, or uh, white. White means cotton white, okay, cotton white, cotton wool like. Now what is the appearance of this tympanic membrane? Wet, blotting, blot paper like appearance. Treatment: first of all, you'll wash everything over here, the fungal debris, everything, just wash it by syringing. Clear syringing. Clear all the water after syringing present in ESC. Why to clear all the water? Because if you keep water, again that becomes a hub for growth of this dead and decayed organisms, and keep your air dry. And now you have to give antifungals. Okay, the antifungal of choice is clotrimazole. Clotrimazole, you keep it 3 drops for at least 10 days and come for a follow-up. There is no pain, okay, in this, so no analgesics, but there is history of itching. Itching is present, okay. So if you use this antifungals, itching will also decrease, okay. Now next thing that you need to remember is about earwax. Very important question, often asked. Earwax can be hard wax or it can be soft wax. So if it's a hard wax, if you need to remove this hard wax, actually if there is an earwax and if it's not creating any problem, no need to remove it, because earwax is useful. It keeps the pH of the ESC acidic. That prevents bacterial growth, okay. So if it's a hard wax, what will do is, and it's creating a problem, oral fullness, okay, hearing loss type of feature, then what you do is you just keep softening, wax softening agent, and that is known as GBS. So what is this GBS? The full form of GBS, it's not Guillain-Barré syndrome, okay. GBS is not Guillain-Barré syndrome. GBS means I apologize here, it is GSB, okay. GSB. This SB is sodium bicarbonate and this G is glycerin, okay. So yeah, here also I told you, no, glycerin is used to decrease edema. Ethamol and glycerin is used, okay. I wrote it here, ethamol and glycerin. Same glycerin is here along with sodium bicarbonate, okay. This actually softens the wax, and this softening, this is actually installed 3 times for 7 to 10 days, okay, 3 times in a day. And after that just go for syringing, okay. So there are actually indication and contraindication of syringing. I will talk about this in the next lecture.